Associate Professor Leigh Tooth, thank you for joining us in the Introduction to Public Health. I've invited you here today to talk about socio-economic determinants of health because you have a rich research background and expertise in that area. Could we start by defining how do you use that term, socio-economic determinants of health?
Sure. So socioeconomic determinants of health are part of a much broader social determinants of health, and I'm sure, like you've had other people talk, it's just one aspect and they all interconnect and they all affect each other as well. So in terms of, I guess if I just start more broadly with the social determinants, if you think about the World Health Organization, we'll define them as the circumstances in which people grow, live, work and age, and the systems put in place to deal with illness. And the conditions in which people do all these things are influenced by the political, the environmental, everything that's going on around them. So it includes things like social environment, family, early life, inclusion, employment, financial security, housing, transportation, food, equity, environments such as green space and toxic air, access to health services and disability. And for Aboriginal and Torres Strait Islander people, it also includes factors such as cultural identity, family participation in cultural activities and access to land. And I know that Francis has or will be talking to this. So in terms of this particular talk, I'll be talking about the socioeconomic determinants. And for these, they're things like, the way that I define them and the way that I use them in my research is education, income and ability to manage on your income, employment, and also things like housing security. So all of those things are some of the more socioeconomic factors that I look at in my research. And they're all so closely related. And so, for example, a higher level of education will lead usually to better employment prospects, which will lead usually and often to less income stress, and which will lead usually, not always, but often to better housing. So you can see how they're all related and they're all interdependent. And you can see how that pattern can be systematically affected through generations. So that you've got disadvantage in one or two of those areas can lead to further disadvantage over time. And those things can then impact your health.
Professor Tooth, can you give us some snapshots of socioeconomic determinants in Australia?
Certainly. So this data comes from the Australian Institute of Health and Welfare, which is a very good site for all information and statistics about Australians and their well-being. And so just some general facts about what things are happening in terms of socioeconomic determinants. So when you think about higher education, so the percentage of people who have a higher than grade 12 education has increased quite dramatically. For example, in 2019, 65% of people in Australia aged 25 to 64 had that higher than school level education, compared to 48% in 2004. So if we talk about people living in low income households, so in 2017 and 18, about 10% of Australians are living in low-income households. And interestingly enough, this percentage has not changed dramatically since 2004. So it ranges between about 9 and 13, 14%. If we want to talk about the percentage of people living in a house where no one's working. So the percentage there overall, there's been little change over the last 5 years at about 10%. However, it depends on the relationship status or the family status. So, for example, in a household with a single parent, the percent who do not have anyone employed is 40%, whereas in a household with 2 adults, it's 5%. So that's another example of how interrelated some of these determinants are. And social status and relationship status, marital status is also one of those determinants that weaves its way in. If we talk about people in employment, we can say that the proportion of adults who are employed has increased over the last 15 years from about 70% to about 75%. However, in recent data show that quite a high proportion of those people are underemployed, so they're not working the amount of hours they'd like to, or that they're available to work. And just another statistic is to do with income stress or rental stress. And in 2018, about 43% of households who were low-income household reported rental stress, and that means they're spending more than 30% of their gross income on housing costs, and that's a rise of about 10% since 2008. And then, of course, we have to think about the impact of COVID on all of this. It's very comparative new data. Now, it's been known for centuries that pandemics disproportionately affect the poor or the disadvantaged. It's been known for many, many years, and COVID is no exception. And again, has shed light on the broad disparities in society. So just some examples. For example, a homeless person or a family is at high risk of viral transmission because they may not have a safe place where they can live and socially isolate from each other. They may have very crowded accommodation, they might be in hostels, they might not be able to access centres in the cities where because everyone's in lockdown, so they're at high risk of viral transmission. They might have less access to PPE, they might have less access to a COVID test and less access to a hospital, and they might not be able to afford insurance. Also things like current or former smokers, and they often are linked to more sort of socioeconomically challenging sort of situations, maybe more likely to get worse COVID symptoms because of their smoking. And also people in very precarious employment positions might not be able to get time off work to get a test. If they're found to be positive, they can't afford to not go to work, so they have to, so they go to work even though they might be positive. So these are some of the sort of the socioeconomic issues that can affect people and their health.
That's given us such a clear idea of the different ways in which people are living in Australia, the diversity of incomes and family structures, and you've started taking us on that link to their individual health. Is there anything you wanted to add about how socioeconomic determinants of health directly or indirectly affect human health?
Oh, certainly. So, I mean, I've already mentioned a couple of the ways that they do, but a classic example is we've shown, and it's been known for a very long time, and I've shown it in my own research, that people with less education, who have had less opportunity to learn, have more unhealthy health behaviours. So they're more likely to do things like smoke or to not follow guidelines for healthy behaviour. They're more likely to have food that isn't as nutritionally rich, or more likely to be overweight or obese, or to not participate in activity. And so that cascading effect of not having that education has led to them having poorer health and poorer health outcomes, and possibly not only for them but for their children as well. Not having anywhere to live, it automatically causes a lot of mental health stress. You can imagine physical health problems. So there's some of the direct impacts. I've got some information here, again from the Australian Institute of Health and Welfare, about Indigenous Australians. This was a report that was done in 2018-19. And they were looking at smoking in Indigenous Australians. And they showed that the proportion who did not smoke were more likely to be employed than not employed, and that's a difference of almost 20%. They also showed that Indigenous Australians who had completed Year 12 or equivalent, compared to those with a Year 10 or lower education, were much more likely to be smokers. And we all know how detrimental smoking is to health. And that report actually quantified the role of some of these social determinants behind the average health gap between Indigenous and non-Indigenous Australians. And so they found that more than half of the health gap between Indigenous and non-Indigenous working age adults can be accounted for by 5 socioeconomic determinants. And they are employment and the hours worked, the highest non-school qualification, so going on to get a master's or a PhD or a certificate, the level of schooling, as in within that 12 years completed, the adequacy of their housing, and also their household income. And then there were also some health factors as well that accounted for that.
And so what you're helping us imagine here, not just Indigenous Australians, but other people who also might be fitting into those 5 categories, and why they might smoke, and then flowing on. So it's not just about choosing to smoke. It's a structure that's being set up, a structure of disadvantage, poverty, lack of opportunity, perhaps some depression or mental health about the future. So I'm really appreciating where you're taking us by giving us this very complex picture of health, and also in terms of resolving it and reducing smoking rates, for example, amongst the Indigenous Australian population. A lot of those upstream effects have to be addressed to give people a healthier opportunity in life.
Yeah, absolutely. And the earlier it starts, the better. So, when the child is born, they say even before the child is born, the more educated the parent, the better off the child will be. The more educated the child, the better off they will be. And so the situation goes. You asked before about indirect effects.
Yes.
So I've also got some examples of that. So an indirect effect, or an indirect way that a socioeconomic environment might affect health, is something like, generally speaking, in a city or a large area, if that area is socioeconomically deprived, it may have poorer or broken infrastructure, for example, or less community services that might be available. And so that situation might lead to people being less likely to use facilities in the community. It could be a playground for their children, or it could be a community group. So they could be less likely to use it, which means their physical health might be affected, or their mental health might be affected. They might feel more isolated, have more significant mental health stress, less social interaction. And also things like socioeconomically deprived areas might also be closer to major roads with high levels of air pollution, or they might likely to have a high proportion of employment situations that are potentially hazardous to workers because of poor working conditions or toxic materials or whatever it is. So that's kind of one way that it can be an indirect effect. Another way is that if you're in a precarious work situation, and by that I mean you're exploited, you have difficulty securing work, you have adverse work conditions or hazardous work conditions, you're overworked or you're underpaid, or you might have limited or irregular hours. You may have less access to sick leave, for example, or your company may not support you having time off when you really need it, when you're unwell. These people are also more likely to lose their jobs. And so, and these people often have other historical disadvantage. They might be more likely, due to their ethnicity, due to their migration status, due to their class, due to their gender. And so these factors here indirectly could mean poorer health.
Wow.
So it's all interwoven. It's not just one thing. And we all know somebody who has no education or very little education, but who is healthy, who lives to be 100, who does great things. And of course there's going to be those people. But when we're talking about population-wide statistics and you're talking about country-wide statistics, those patterns that I've talked about are very clear.
Wow. So let's stay with those patterns and talk about your research. And a lot of it is conducted through the socioeconomic determinants of health lens.
Yeah.
Tell us a little bit and continue to bring it to life for us.
So I guess I work for the Australian Longitudinal Study on Women's Health, which is a study that's been going for about 25 years. And we have over 57,000 women in across Australia. So the study started back in 1996, and we had women in different age cohorts, so women who were 18 to 23 years, 45 to 50, and 70 to 75. And so these women we have been following. And so one of the key questions we ask, We ask everything about their health you can imagine, but one of the key set of questions we ask is about their education, their employment, their income, how they manage on their income, those sorts of socioeconomic indicators, as well as a whole host of the other social determinants of health. And so I'll just talk about two different pieces of research that you might find of interest. And the first one looked at educational mobility. So this is looking at somebody at age 18 to 23, or basically when they're an adult, if they go on in subsequent years to sort of further their education compared to if they don't. And so that's called intra-generational, so within a generation. And then we looked at if their achieved education was different, was sort of higher, the same, or lower as their parents, which is intergenerational. And so we wanted to know, do women who increase their education from the age of 20 up to 40, what's their health like compared to women who don't? And so we looked at women who were of that age, at about 18 to 23, and what we found was that women who over that subsequent 20 years had improved their education, so they might have, at age 23, they might have had school, grade 12, and then at age 40 they might have a PhD or they might have a master's degree. We found that those women who showed intragenerational mobility compared to women who did not had much better mental health and physical health using the established scales that we measure. So in doing this research, we found one really interesting finding, and that reflects basically where you start on that educational journey. So if you have a young woman who's 23, who already has a degree and goes on to have a higher degree, and then you have a woman who's 23 who has school, like grade 12, and then by the time she's 40 has gone on to get that higher degree. So she started from a lower level to begin with. Her physical and mental health is not as good as the woman who was already high or at that medium level. So it's sort of, and this is quite well known in this type of research, is that it's almost like the sooner and the earlier you get your optimal socioeconomic determinants, the better your health will be. So it doesn't mean you can't get there, but you possibly won't do as well as if you've done it earlier, which harks back to the whole issue of, start from when the child is born, give them the best education from, the minute they can talk, basically, to really improve their sort of thing in life. And so then the other aspect of that research was whether they did better or worse than their parents. And so we certainly found that women who were more educationally mobile from their mothers and fathers, particularly their mothers, had much better health, and that women who sort of stayed at that same low level, it could have been grade 10 education or it could have been grade 12, had poorer health. So they weren't as educationally mobile. So that's that intergenerational effect. And then the next bit of research that I guess shines a light on some of this was looking at physical functioning in women across different age groups. And so here we looked at how socioeconomic factors were associated with physical functioning. And that's questions like, can you walk? Can you climb stairs? Can you do self-care? Can you do exercise? That sort of thing. So they're physical abilities, really. And again, we followed the women in those three age groups and followed them for about 15 years. And what socioeconomic factors that we measured were level of education, managing on their income, and we also had a different measure this time. We had a measure of the socioeconomic environment of the neighbourhood in which they lived, so that whole idea of place. And these are based on indicators such as, sort of average income, average employment, that sort of thing that's within that location where they lived. So we had some individual level measures and the community or the area measure. And what we found was that in each of those three cohorts of women who were aged in those three sort of stages of life, women who had the most difficulty managing on their income showed the poorest physical functioning over time. So that's across the three cohorts, so young, middle-aged and older women. So not only was it poorest at the beginning, but it was poorest at the end. So it might have changed over time, but it didn't change as much as women who were okay or had less income stress. So we also found that in terms of decline in physical activity, it was women in the most disadvantaged neighbourhoods who showed the most rapid decline compared to women who lived in more advantaged neighbourhoods. And what we found was a bit of a difference by age as well. So for middle-aged women, we found that difficulty managed on income and lower education were more strongly related to their physical functioning and to the physical functioning declining than it was in, say, the older women, where it wasn't as important.
Wow. So what you've given us there is the first example is all about educational level and how that ultimately affects health. And then that second example is quite amazing. It was income, and then income probably influences your neighbourhood where you live, and then those features can affect your physical functioning. So, you're really emphasising what we've been learning throughout this course about the interconnection of so many factors.
Yeah.
And then you've got that overlay, that amazing research that's longitudinal, where you've followed those women over time, which kind of really emphasises the picture.
Yeah.
So we really need to wrap up now, but I was just wondering, are there some last words or a last message that you really like the students to carry away with them?
Yeah, I would. And I feel I need to quote some words from people who are much wiser than myself. And these are from people who are eminently qualified in this whole field of social determinants and health equity. So the first quote is by authors Kate Pickett and Richard Wilkinson. Now, they wrote a very excellent book called The Spirit Level, and Why More Equal Societies Almost Always Do Better. And that was published in 2009. It's well worth looking at. So the quote is, "The average well-being of our societies is not dependent any longer on national incomes and economic growth, but the differences between us and where we are in relation to each other now matter very much." Now, the second quote is by Sir Michael Marmot, who led 2 key reviews into social determinants of health and inequalities in the UK. And the quote is, "The levels of social, environmental and economic inequality in society are damaging our health and well-being. We must build a society based on the principles of social justice, reduce inequalities of income and wealth, and build a well-being economy that puts achievement of health and well-being rather than narrow economic goals at the heart of government strategy."
Associate Professor Leigh Tooth, thank you so much for talking to us.
My pleasure.